thank you, and thank you to the organizers of SSG. I was here as a student, basically, in my fellowship to learn the six pillar, and today I'm invited to give a talk. So very honored. Thank you. My name is Raghuram Sampath. I am with a medical group in Oregon called Northwest Permanente, and I work at a Kaiser hospital. Uh, I'll go quickly as it's my last talk. Then we have some questions for audience response. I hope I'll keep it as interesting as other previous talks and still keep it short. I've got no disclosures from my side. So this is a 51-year-old female. So we're talking about the index presentation now, but years ago, almost 13 years ago, she had a AVM located on the tentorium on the left side, being primarily fed by PCA. This was embolized, radiated. Now it fast forward 13 to 14 years later, where she presents with dull headaches, but mostly dizziness, imbalance, and just the head feeling fuzzy. We get an MRI. We have this appearance of this post-embolized and radiated AVM in the past. There's a lot of edema. So we admit her, place her on steroids, and within 2 days, her symptoms have improved. Then we think probably that was the only treatment, and it made her symptoms improve. So we discharged her. Of course, we got an angiogram to confirm that there was no residual filling within this AVM, and what we found is indeed it is a cold or dead AVM. So 3 to 4 months almost later, she presents again with more dizziness, complaining of some dull headaches. And her dizziness is that the room is spinning, my head doesn't feel right, I cannot walk, I'm wobbly on my feet. So again, we start the same imaging investigation, CTA, MRI, and angiogram, and this time we find the lesion is stable in size. The angiogram still shows there's no filling, but I'm seeing the same pattern of edema. And now she's also complaining of some visual field deficit. And we also start seeing a trapped temporal horn. So, we start her on steroids again, she improves, but then will we keep doing this again and again? So now we have hold a discussion with our radiation oncologists and medical oncology physicians to say, what else is the approach here? We discussed possibility of Avastin, possibility of even as far as going as far as thinking about anti-MS medications. And then finally, we decided surgery is an approach, but if we are going to do surgery, what's the approach? And, with her vision loss, I obviously want DTI imaging to have knowledge of her optic radiation. So we again, as she improved with steroids, we discharged her again. And within a week, she's back. And this time, her visual deficit is complete and she has worse headaches. And I don't know if you're able to tell, the temporal horn here is very trapped and immensely enlarged. So now it's a more urgent procedure to take her for decompression of this. I don't have DTI, but I've got to still come up with a plan of what my trajectory will be to avoid any kind of traversing damage to the optic radiation. So we positioned her. My approach for this was going to be using a MIPS technique. I had a parietal entry point marked out using navigation. I also had a point in the temporal lobe more anteriorly in case I need to cannulate the ventricle and decompress it right away. In case there's any complication or more brain swelling, if I have to make a bigger flap and do a craniectomy, I kept my incision prepared for that as well. And in the event I may have to change course during the MIPS technique and I have to go more skull-based, as in go supracerebellar and transtentorial to get to this very medially located tentorial lesion, supratentorial region, I kept that approach available. So I kept all of them available. But what I ended up using was the brain path technique using navigation. I went through the parietal entry point, parietal occipital entry point. My first attempt at this was to see, okay, my angiogram confirms there's no filling, but is there still something that may bleed a lot? So I use 2 suckers at the beginning, make sure that this is indeed a chronic encapsulated intracranial hematoma or CEIH. Once that's done, then I know that I can remove this piecemeal. I use the Nico Myriad and we debulk it and remove it in piecemeal. This is a very interesting picture. Once we're all the way through the mass, we're looking at the tentorium here. And the next slide, we're looking at the 4th cranial nerve. So when I'm at the medial edge of the tentorium and I'm seeing the trochlear nerve here, then I know that, okay, the PCA and the other genitourethalamic perforators coming from it are close by. And this is where I want to, not take surgery or resection anymore. I got most of the mass out. So then her post-op imaging, she's, the edema, the mass effect is gone. The temporal horn is also looking well decompressed. She's extubated. The surgery lasted less than an hour. And during the course of follow-up, the only thing that didn't improve was her vision. Peripheral field defect remained, that didn't change. But as you can see, the small portion that I left on the, oops, sorry, on the tentorium very medially, that's still there, but her dizziness has improved and she's happy with the symptoms, the resolution, and she's back to work. So this was one unique case for me. I had not done anything like this at that depth on the tentorium that had a previous history of embolization and close to, posterior fossa blood vessel. So anyway, I wanted to share this and see what the group thinks about and take back any valuable points. So there's a question session at the end. Would anyone have done surgery at the first presentation when she initially presented with the dizziness and when we treated her with steroid? Should we have admitted her and done surgery right away? Oh, clearly I didn't do that. She did improve. I gave her steroids and we discharged. So something, it should have been done the second time at least. No one would consider Avastin, no medical management for this. Okay. And yeah, there some other approach other than what I used. I'll be interested to hear if anyone can tell me what other approach would have also been a good choice here. Okay. So I'll move on to my next talk. Again, no disclosures. This was a young patient who didn't live too far from the hospital, just within a mile, and collapsed at home. He's non-compliant with his antihypertensive medications, history of alcoholism, cannabis use, not a smoker. Collapsed at home. EMS got to his own quickly, intubated on the scene for airway protection, and relatively very quickly, within 30, 40 minutes, the emergency room. So, he's just been intubated. There's some paralytics on board. I don't have a great exam on him. Pupils are reactive, blood pressure's very high, 220s. He's been treated for that. His GCS, again, I don't have a great exam, but it's about 6T. Then we go on to get a CT head with CTA. And could we play the video or can I do it here? Yeah. So this is his initial CTA showing ICH and some IVH, but what volume about 100 cc's is what I calculated. What caught my attention here was that there was a portion in the frontal lobe, of course, it's going all around, and there's another portion that's extending in a long axis in the temporal lobe. And I was thinking, if I'm going to evacuate, and as we all know, maximum amount of removal of the ICH is what leads to better outcomes. And I was thinking to myself, how will I get all of this out in one go? And if I separately calculate just the portion of the volume of blood in the temporal lobe, it came out to a significant, around 18 to 20% of the total ICH volume. So I said that portion, leaving it behind, really doesn't, go well with what we have learned about maximum removal of the clot. So that's where I planned that I might have to do, and this is very different than another case. So this is another case. This is our usual where a single port approach to removal of the hematoma works. But the case I had in front of me was not something similar to this. So that's why I thought I may have to do a dual port here. So my first entry point was going to be the frontal, and I used one of his frontal crease and I marked that out. I also kept a temporal approach to reach the plot within the temporal lobe. So that's why I used navigation, had two trajectories, and just in case I had to do a bigger craniotomy, in case there was any complication during surgery, I kept a flap ready, skin marked for a flap. And that's what I did. I used two ports. So this is in the frontal entry point, and this is the temporal. I made both the craniotomies at the same time. Dura was opened soon after the other, and then the frontal port went in, and quickly enough, I also put the temporal port in because I know brain can shift. I did have ultrasound available in case I didn't find the temporal plot and I had to locate it. Can we play that video? We can go quickly through that. Yeah, so this is, and I'm also limited by a large frontal sinus, so I can't be too low, but because of that, I'm also not able to angulate my brain path cannula too far back, so I'm a little limited by that. And the way I do it is I create a long projection on the navigation instrument, and as I'm entering, I ask my navigation rep to keep cutting down one centimeter. That is true. As I'm going in. So that's how I use navigation along the long aspect of the hematoma. So anyway, this was done, and this is the end. So close the frontal incision just for cosmesis, got a good subcuticular sutures there, close the temporal one with staples, immediate post-op CT. So I think this is about greater than a 90% evacuation. I don't think I could have done any better with this, with the approach and some limitations I had. He was extubated on day 2. Of course, he is a known alcoholic and had some DTs and blood pressure issues. That's why he stayed in the ICU a little longer. He was transferred out to the step-down unit on the 3rd day and then discharged almost a week later. And we have a CT. This is 1 week post-op CT, again, showing that there's no recurrence of bleeding, or whatever little blood was remaining is slowly dissolving. And then I saw him back at his 3-month visit. The incision on the forehead healed well. He's walking independently. Of course, he wears an ankle orthosis. The right arm is weak. That didn't improve. But the imaging, again, at this point shows that, my approach, and one of our previous speakers admitted about using the middle temporal gyrus. And if you look at my temporal approach, that's where the entry and trajectory was. So overall, just wanted to share these 2 quick cases with you. I had never done one with 2 ports. I've seen being used as a co-surgeon. I was involved in a butterfly glioma where we had 2 bifrontal ports, but this was the first hematoma that I had used 2 ports. And I tried to do a literature search quickly, and I didn't find much reported on this. And there was some other talks in the morning where, you don't have only a long axis hematoma, but some kind of finger of projections. I think in this case, I thought this was a good outcome for this patient using the 2 ports. Of course, he's young. He was brought quickly to the hospital. We took him quickly to OR. So I think all that affected is good outcome. I think I have some questions also for this at the end.
And I personally have never done 2 ports. What do you advise us? What would you do going forward? Do you think it was better? You obviously got a good outcome.
I think you have to wait, as the idea of MIPS is minimal tissue damage, but if you're putting a second port, there's some additional tissue damage from that. But if you get a good outcome, I think it justifies everything that you've done. It's just knowing where the eloquent, avoiding the superior temporal gyrus in this case, and other usual pathways that you have. Yeah.
Going long axis, going low, but some people don't like to go through the frontal sinus. I'm one of them. You can if you absolutely need to, but yeah, I think those are good lessons learned. Thanks for sharing them.